The Soulmate is an implantable device designed for real-time, continuous cardiac monitoring and pacing functionality that has significant commercial opportunities in 3 areas: cardiac transplant, coronary artery bypass graft, or CABG, and heart valve replacement surgery. There are nearly 5,000 heart transplants performed annually worldwide, with nearly 60,000 patients that are living in the world with transplanted hearts. The Soulmate addresses issues that are relevant to the monitoring and aftercare of a transplant patient. The coronary artery bypass graft, or CABG surgery, is performed on approximately 540,000 individuals annually, with over 11 million people alive on the earth who have undergone this surgery and are therefore potential candidates for Soulmate therapy. Nearly 250,000 heart valve procedures will be performed in the world every year, and that number is expected to continue to grow over time. As you can see, the broad spectrum of capability of the Soulmate makes it an absolutely vital tool for the management and care of millions of people in the world. Post-cardiac transplant monitoring is addressed in the following video. In a recent study published in an American Heart Association journal, the Soulmate was found to have demonstrated the capability in real time to accurately and non-invasively detect early acute transplant rejection. It was concluded that this approach could be used as a non-invasive tool to potentially reduce the number of biopsies needed and result in earlier detection and treatment of rejection. Ultimately, the Soulmate system would offer a method for less invasive and more effective management of heart transplant patients.
Hi, I'm Dr. Charles Richardson. Each year, more than 5,000 patients worldwide undergo a heart transplantation. In the next 15 minutes, you're going to watch a video that's going to show you how cardiac rejection monitoring is done and how TransWorld is going to impact and revolutionize medical technology as we know it today.
I could not walk from my bed to my bathroom without leaning on the vanity, and I would sound like I had just run the Boston Marathon. I got my new heart in September 19th of '94.
Transplant patients, their biggest risk is rejection during the first year or so of following the transplant.
Right now, after a patient receives a heart transplant, a so-called allograft, we have to monitor it for rejection. Anytime we move tissue from one individual into another individual, whether it's blood or solid tissue, the native immune response designed to protect us from foreign invaders, if you will, is revved up. And pretty much all evil is generated by rejection in patients who have organ transplants.
I've had 2 rejections. The first, well, actually 3. The first original rejection was one that's always expected after a heart transplant. It's not abnormal. I had a minor rejection a couple of months later, and it was treated simply by a higher dose of peel-form and was doing really well. During one of my other biopsies, it showed a rejection 3, grade 3. They immediately called me, wanted me in the hospital to counteract that immediately, and they went with a higher dose of prednisone. They went from 10 milligrams to 1,000 milligrams for 3 days. Treatment didn't take that long. I think the treatment was approximately 30 minutes or so, if they're even that long to do it, to get it in, but it was a matter of staying the 3 days to get it done. It had to be done IV form. It couldn't be peel form.
We have learned that controlling this rejection process is possible, but what we have to do is measure somehow the degree of that rejection that occurs. And how we do it for individuals with heart transplant is a bit draconian today. Hasn't really changed over the last 2.5 decades that we've been doing heart transplants, and involves inserting a catheter into the neck, into a large vein that runs into the neck, the jugular vein, and pushing that catheter, which has pincer forceps on it, a biotome, into the right ventricle and then taking multiple small pieces out of the right ventricle and pulling them out and looking at those pieces under the microscope.
Okay. One. Yeah, you felt that? Mm-hmm. Okay. Just a little pressure. Oh, I'm sorry. You felt that tug? I felt it. Oops.
That is an invasive procedure that has significant morbidity associated with it and occasionally severe complications.
I think the number one thing that is the most difficult thing to tolerate about the biopsy is that it is very invasive. It's a needle into the vein, wires, catheters, getting heart tissue. So there are risks involved, and that's primarily the bleeding, the infection, which is minimized by doing it in a sterile, controlled setting. But there's always risk of causing a very small perforation in the heart, albeit rare, but still a risk that's present. And also pneumothorax, causing air around the lung by putting in catheters into the veins.
Now those severe complications include pain that the patient goes through simply from having the puncture, the venipuncture in the neck, and the discomfort of having to go through a catheterization procedure. But it can also include pneumothorax, which is a collapsed lung, and a variety of other potentially more harmful complications.
Well, to do endomyocardial biopsies does take a lot of resources. It's associated with risk. You can damage the vein, blood clots can form, you can even puncture the heart or put holes in some of the vascular structures.
I've had my lung punctured at least once, and I think probably more than that. One time it was a week in bed at home with a stabbing pain going through my body every time I took a breath, and then the other time I was in the hospital with a stomach tube.
The major concentration of rejection occurs in the first year. However, the patient is going to indefinitely have biopsies in the transplanted heart. They actually reduce to as few as 4 times a year after a certain period of time, but in the first 2 years, 20 to 30 biopsies are the norm.
The patients come in for this invasive procedure, and it does cause some pain and difficulty. And also, you're only seeing one very small picture in time. The only information you get is what's actually happening at the time you take the piece of the biopsy. It's also limited by the fact that daily information, daily biopsies, or even weekly biopsies are a challenge and are difficult. So it does, endomyocardial biopsy, though giving good information, it does require some effort. It's associated with some significant morbidity, and it's not very pleasant to the patients.
Here comes that cold soap, okay?
I'm ready.
Just what you need, more cold.
Yeah, give me a minute and I'll stop shivering. Oh, I thought your hand dry. Yeah, I'm fine.
Camera, come over. Would you walk with me, Kat?
A little bit of burn. Stick in the burn. Numbing medicine. Let me know if you feel anything but pressure. It should all just be pressure.
Okay.
Now that the sheath is in, we're going to go in with the bioptone to get your heart biopsies.
Despite the fact that invasive procedures are uncomfortable, they're also dangerous. And a device implanted at the time of surgery, which would allow non-invasive monitoring, eliminates most of the complications associated with the follow-up of this particular aspect of transplant care.
Many different attempts have been made to try and come up with other ways to assess rejection. And these have ranged from blood test measurements, urine test measurements. Some have helped, and there are some new tests coming out that may prove beneficial. But the concept of using a pacemaker type of device that is implanted at the same time the heart transplant is done, that would measure certain electrical characteristics of the heart, and also be able to provide certain therapies with the pacemaker should they be needed, is really a novel, a unique concept, and one that could entirely replace having to do invasive endomyocardial biopsy to get the information.
Any measures that are non-invasive will be always of great interest to both the patients who have had heart transplant and the care providers who take care of them.
Biopsies are expensive. Not only do you have the time involved for the physician and the room requirements, you have the pathology requirements and a variety of other costly aspects of evaluating that form of rejection.
With this particular device, one of the unique characteristics is the fact it's also a pacemaker. And patients after a heart transplant frequently need pacing. And so it has several different opportunities, one a diagnostic opportunity, and two a therapeutic opportunity that could be beneficial in the heart transplant recipient.
This device, when proven effective, will become extremely important, not only to the patient, but also to physicians who take care of those patients, and very quickly by the insurance companies, because it's so much more cost effective than what we're currently doing.
Since this device is put in at the time of the operation, at the time of the heart transplant, and since the device really resembles a pacemaker, and we have lots of experience with pacemakers in these patients, we believe that it is safe, and in fact we believe that it will be much safer than doing endomyocardial biopsies, because it likely won't be associated with all of the trauma that is associated with a central venous puncture and an endomyocardial biopsy. I envision two types of participants ultimately in clinical trials that are designed. First, individuals that are undergoing a heart transplant. So on the day of the transplant, actually it's usually in the wee morning of the hours, at the time of cardiac allograft insertion, at the time of the actual operative procedure, I envision these devices being placed then. And the devices being used really from day one after the transplant. And then I would envision clinical trials being done with individuals later on who have already had a transplant, who haven't had the opportunity to have the device put in at the time of transplant. I envision those patients getting the device and going into some different clinical trials at that time. So I look for both acute insertions of the device and insertions in patients who are out more chronically.
The current method of acquiring information from this particular detection device is simply by having a handheld Palm Pilot, essentially, that you hold over the device. That's done twice a day for less than 5 minutes, and it downloads a remarkable amount of information directly to the internet, and so that the patient never has to come in. It's simply a resting evaluation with a Palm Pilot over the device.
At the time of transplantation, a pacemaker-like device called the Soulmate is inserted into the abdomen and leads are sutured to the heart. The soulmate then begins gathering information about the heart's rejection levels. This data is then transmitted and read outside the body by a handheld device connected to a palm-top computer. The gathered data is then sent via internet connection to a central monitoring station where medical professionals will interpret the data and take appropriate action if necessary. While represented in the preceding animation as having been implanted in the abdomen, the soulmate's more likely placement would be in the traditional location of permanent pacemakers in the upper chest area, pictured here.
One important question is whether or not a device like this would be cost effective. And my opinion is it would be tremendously cost effective for several different reasons. Number one, it would obviate, I believe, the need for bringing patients back for sequential heart biopsies, which is in effect a cardiac catheterization study. So those would be eliminated or would be decreased. And then you would also eliminate complications of endomyocardial biopsy, which does add to the overall cost of managing a heart transplant patient. And finally, though speculative, because I believe this information would be helpful in managing the patient and therefore decrease complications from allograft rejection, I think the cost of managing those complications would drop. So if you look at the grand scheme of things and you look at the overall contribution to cost management in the patients, I think the device is going to prove effective to decrease the cost of treating a heart transplant patient overall.
It's certainly not a comfortable thing to go through. You have to fast before each procedure, and it'd just be wonderful not to have that invasion into my body.
Well, I already have been through this and knowing what it's like. To be able to have it done and not have any kind of invasive thing and still acquire what they need for knowledge, it would be great.
No more travel to the hospital. No more invasion into the body. Significantly less complications at a fraction of the cost. The soulmate truly is tomorrow's medical innovation today.